In this video, dissection of the superficial back and the scapular region will be demonstrated. This work was produced by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. I am sure someone in history must have said that strong backs build nations. Unfortunately, evolution has not been kind to the backs of bipeds, that is us, and if we do not treat our backs well, they will let us know. Let's start the dissection of the back. The back is often the first area that new students dissect because the structures of the back are large and thus cutting too deeply or widely does not typically cause major harm to the didactic value of the dissection. There are various approaches to removing the skin of the back. Here, we show the locations of cuts that are typically made to begin the removal of the skin. Of course, the horizontal cuts are made on both sides. For cadavers that are fixed, that is, injected with preserving fluids, we typically remove the skin and the underlying fascia, known as the superficial fascia, in one step to save time as shown here. It is possible to remove the skin alone, but this is very time-consuming and does not generally provide for increased understanding of the structures of the back. As noted in the text, the superficial fascia is embedded with fat and thus its thickness varies among individuals and in different body regions. All cutaneous nerves and vessels must pass through the superficial fascia to reach the skin. In order to clearly see the fibers of the muscles underlying the superficial fascia, we also typically need to remove some of the very thin, non-fatty deep fascia that encases the muscle. This slide shows the process for doing so. Here we see the structures of the entire back visible when the superficial and deep fascia are removed. We'll look at these structures and the underlying ones more thoroughly in the subsequent slides. The trapezius is the major superficial muscle of the upper back. This trapezoid-shaped muscle has wide attachments on the back of the skull, the clavicle, the spine and acromion of scapula, and the cervical and upper thoracic spinous processes. You can readily see the differences in the orientation of the upper and lower fibers of this muscle. The upper part of the trapezius will rotate the scapula upwards, whereas the lower fibers will rotate the scapula downwards. After the trapezius is revealed and studied, it is typically reflected, as shown here, by cutting its medial attachment of the muscle. Then, reflecting the cut muscle superiorly. This will allow you to examine the nerve, the spinal accessory nerve, or cranial nerve 11, and the underlying muscles. Once reflected upwards, the spinal accessory nerve is readily seen, traversing the deep surface of the muscle. We now can also see parts of the supraspinatus, infraspinatus, levator scapulae, rhomboid minor and major, and posterior deltoid muscle. The spinal accessory nerve is accompanied by the transverse cervical artery and vein. The nerve and vessels were colorized in the image to better demonstrate them. Further reflection of the trapezius reveals more of the muscle shown on the previous slide, and additionally, we can now see the teres minor and major, the long head of the triceps brachii, and the splenius muscle. For orientation purposes, we have placed a bony scapula on the cadaver. Remember that upward and downward scapular rotation is defined by movements of the lateral angle, that is, the glenoid fossa. The axillary nerve supplies the deltoid muscle and is often injured in humeral dislocation. To reveal this important nerve, the posterior deltoid is reflected from its attachment on the spine of the scapula, as shown here. After reflecting the posterior deltoid, the axillary nerve can be seen embedded in fat on the deep surface of the deltoid muscle. This nerve is a major branch of the posterior cord of the brachial plexus. It is accompanied by an artery, the posterior humeral circumflex artery. In addition, a small branch from the axillary nerve emerges to supply the teres minor muscle. Before continuing with the dissection, let me say that dissection of the scapular muscles is one of those confusing areas for beginning students. The scapula is the structure of the back, and we dissect the muscles when we are dissecting the back. But the muscles attached to the scapula work on the upper limb and are pertinent to know in limb dissection. Thus, you see these muscles now, but will not truly learn what they do until we spend time studying the upper limb. The tendons of the three muscles we have identified here, the supraspinatus, the infraspinatus, and the teres minor, will contribute to the shoulder capsule known as the rotator cuff. Another muscle, the subscapularis, present in the front, will make up the fourth muscle. We will go into much more detail about the rotator cuff when we study the upper limb. Nevertheless, it is customary to dissect these muscles at this time. The goal of this dissection is to demonstrate the nerve that innervates the supraspinatus and the infraspinatus muscles, and in order to do this, we need to reflect the muscles laterally as follows. Once again, identify the bony components we have identified previously, the spine of the scapula and the acromion. Next, identify the muscles, the supraspinatus, infraspinatus, and posterior aspect of the deltoid. Using a scalpel, we cut the infraspinatus down to the scapula, then begin reflecting the muscle laterally. The muscle needs to be reflected until a neurovascular bundle entering the muscle is found on its underside. If we trace this bundle, we'll see that it passes around the spinoglenoid notch, which is located at the lateral end of the scapular spine, inferior to the acromion process. We next do a similar reflection of the supraspinatus. We continue to reflect this muscle until we find the suprascapular nerve and artery entering the supraspinous fossa from the infraspinous fossa. In reality, we're tracing the nerve backwards because it originally entered the supraspinous fossa through the suprascapular notch on the superior margin of the scapula. Finally, we demonstrate the continuity of the nerve we just identified in both the supraspinous and infraspinous fossae, showing that the same nerve, the suprascapular nerve, innervates both the supraspinatus and infraspinatus muscles. This nerve can become compressed in the suprascapular notch, causing a palsy in both these muscles. If we now move to the lower back, the principal superficial muscle is the latissimus dorsi, the most powerful extensor of the arm. It has a wide origin from the thoracic and lumbar spinous processes and inserts into the bicipital groove of the humerus. The muscle is reflected by cutting through its proximal attachment and reflecting it laterally. With the reflection or removal of the superficial back muscles, the first intrinsic back muscle group is revealed, that is, the erector spinae group. This muscle is arbitrarily divided into three longitudinal muscle columns, from lateral to medial, the iliocostalis, the longissimus, and the spinalis. As a group, these muscles function to extend the back. Deep to the erector spinae is a second group of intrinsic back muscles known as the transversus spinalis group. These muscles are revealed by removing some of the erector spinae muscles as shown here. Here we see some of the transversus spinalis group of muscles which are primarily concerned with small movements between individual vertebrae. Here again is a slide showing the muscles of the back after removing of the skin and the superficial fascia. You will need to know the identity of each of these muscles, their innervation, and their action. We now conclude this video, the dissection of the superficial back.